Good afternoon. I'm Dr. Susan Chandler from the Integrative Health Program at Massey Cancer Center. Today, we are very pleased to have with us Dr. John Quillin. Dr. Quillin is a genetic counselor at VCU Health, and he's also an associate professor with the VCU Department of Human and Molecular Genetics. He came to VCU for graduate training back in 1997 and has been providing cancer genetic counseling since 1999. Dr. Quillin is passionate about the promise of new science and age-old wisdom for helping people with hereditary cancer restore or maintain their health. Now, you've been muted during his presentation, so if you do have questions, please refer to your comment section and we'll be monitoring for those. Dr. Quillin, thank you again for being here today.
Thank you, Dr. Chandler, for asking me to be here, and thank you to the Integrative Health Program at VCU Health for all of the really wonderful services they provide. So today I get to talk with you about genetic testing for inherited cancer risk. That's something that, maybe 10 years ago, not as many people knew about. And now some studies show that about a third, if not more than half of patients with cancer will be appropriate for having genetic testing for inherited cancer risk. And even more will have their biomarkers, genetic biomarkers, looked at in their tumors to help decide their treatment. But even if you don't have cancer, unfortunately, we know we're all at risk for cancer. And so sometimes genetic testing can help. Sometimes it really can't. And so what I'd like to do in this talk is walk you through the current landscape of genetic testing for inherited cancer risk so that you can be a smart consumer of it. Through this talk, I hope that you'll learn the following. I'm going to talk about genes and mutations, and don't assume that you have any background in this, but I hope that you'll still learn how gene mutations cause cancer. I want you to learn about the different types of tests for inherited cancer risk. I want you to have a better idea of whether you should consider genetic testing for inherited cancer risk yourself or perhaps someone in your family. And ultimately, I want you to know that you can lower your chance of cancer, even if you have inherited cancer risk. Now, why is this important? This information is important because in terms of genetic testing, not all tests for inherited cancer risk are equal. I'll sometimes have folks come to me and say, I'd like the gene test for cancer. And there's not just one, there are hundreds, perhaps thousands. It's important that you know this information because, in fact, most people will not benefit from a hereditary cancer test, or maybe they won't get the information they're expecting to get from it. But for those people who are likely to have inherited cancer risk, genetic testing can be invaluable. It can help clarify risk for themselves or for their family members, and it can guide cancer prevention and screening choices. Cancer is unfortunately too much of a deadly disease and still very much with us. So this is a graph from 2018 and 2019 showing the leading causes of death here in the United States. And cancer is a close second to heart disease. But we're no longer in 2018, 2019. As we all know, we are in a totally different era. And we are in the area of COVID. Which is clearly a public health crisis. And so these are the numbers as of today per the CDC. 497,415 Americans have died from COVID-19. And yet, over the same time period, 608,570 of us are expected to die from cancer this year. So even in this era of COVID-19, which has completely upended the globe, cancer remains a significant burden of health problems. Or put another way, for every 6 baby girls born today, 2 of them are expected to develop cancer at some point in their lifetimes. For every 6 baby boys born today, 3 of them are expected to develop cancer at some point in their lifetimes. So cancer remains a significant public health challenge. Now, why is cancer so prevalent? Why does cancer happen in the first place? Well, we know of a lot of environmental and lifestyle factors that can cause cancer. And that's one of the things the integrative health program can really help us with. We know there are bacteria and viruses. Those are some of the first things that were found to be causes of cancer. But we know some important other lifestyle factors like tobacco, obesity, things that go into obesity like diet and physical activity, alcohol use, underlying medical conditions like immunosuppression and chronic inflammation, sometimes work-related exposures can also all contribute to cancer risk. Importantly, and this will be a theme as we go through, when somebody develops cancer, it's usually not because of just one of these things, but a combination. But the focus of this talk is going to be on inherited genetic mutations, which also contribute to cancer. Now, they don't contribute to as much of cancer as environmental factors do from a population perspective. So this graph shows the proportion of cancer in the population that could be explained by genes, those biological factors that we inherit from our parents, or from environmental factors shown in the blue graph. And generally about a third of cancer in the population can be attributed to inherited genetic factors. And then 2/3 are things that we are exposed to throughout life in the environment. So what do I mean by genetics? What do I mean by a gene? A gene is that little segment of DNA, which is just a biological substance that we inherit from our parents. It's packaged on these structures called chromosomes you may have heard about. And these function really as kind of the recipes for how our cells, how our bodies will grow and develop in a healthy way. We have a lot of different genes. We have 20,000 different genes. And these are inherited from our parents. We get 2 copies of every gene, 2 copies of every chromosome, every package of genetic information. We get 1 copy from mom, 1 copy from dad. That's important to understand because that tells us about how genetic risk can be inherited. So genes are those substances that keep us healthy. So they are there for normal development and growth and functioning of those cells. A mutation is like an alteration in the recipe that causes something really untoward to happen. So for example, imagine we've got a recipe and the first ingredient in that recipe is 1 cup of oats. That's bound to be a healthy recipe. A mutation would be like something coming along with a red marker and scratching out that O and putting in an F. Now, I'm not a nutritionist. I know there are some good fats and some not so good fats, but I suspect if the first ingredient in your recipe is 1 cup of fats, it may not be as healthy a recipe as 1 cup of oats. So that's like a mutation. You've changed 1 letter in that recipe, and that was enough to significantly alter the outcome of that recipe, what it's going to make. Remember, we have 2 copies of our genes. So if we have a mutation in one of these genes that's causing that gene not to make the right recipe, this is how it can be inherited. And so in this diagram, we have a father here who, by a blue letter A, that's representing a chromosome with a gene mutation. And the other dark colored A is a normal, typical recipe for that gene. And so he's got 2 copies. He's got a 50-50 chance of passing that on to each child. His partner there has 2 normal copies of that gene. That's the only one she's going to pass on. So it turns out that about half of the children may have inherited this mutation. It doesn't have to be half. It's a 50-50 chance each time. If you don't like the diagram, you can simply think about it like this. If somebody's a carrier for a gene mutation, there's a 50-50 chance. It's like the flip of a coin as to whether or not a child will also inherit that same mutation. But usually, a mutation in a single gene is not enough for cancer to develop. We have 20,000 different genes, and they all work together like instruments in a symphony. And we also have all of these environmental factors that play into whether or not cancer will develop. Cancer is sometimes called a complex disease or a multifactorial disease, multi meaning many, factorial meaning lots of different determinants, things, risk factors that can cause the disease to occur. One way to think about risk for cancer based on multifactorial inheritance, and I attribute this to Dr. Janine Austin, who's a psychiatric genetic counselor in Canada, is to think about having a jar, just like a regular mason jar. And in that jar are genetic mutations that we've inherited. We've all got mutations. Our genetic code is 3 billion letters long. There are always differences that make some folks more susceptible to disease than others. So those green triangles at the bottom of that jar represent mutations that we've inherited. Now, the key here is not to let the jar overflow. So these blue circles here represent different environmental factors, risk factors, tobacco smoking, for example, that going into the jar may not be enough by itself for cancer to develop, but if that jar fills up and overflows, that's when cancer is going to develop. So the key is not to let the jar overflow. Not all gene mutations are created equal. And so this is a graph showing these series of letters and numbers are just names of different genes. Some of them you might have heard about, like the BRCA genes up here at the top left with BRCA1 and BRCA2 associated with high risk for breast cancer. You'll notice that the bottom half of the curve here shows how common or rare a gene mutation is in the population. So I mentioned BRCA1 and BRCA2, which are up at top, and it's pretty rare. About 1 in 500 of us has a mutation in BRCA1 or BRCA2. That means 499 out of 500 do not. But those are high risk genes. Penetrance is just a word that means, in this case, risk. So all of the genes you see on the top left of that graph are high risk for cancer if they have a mutation, but they're pretty rare. We can think about that jar analogy that the more common mutations are low risk, so kind of small triangles. A little bit more frequent are what are sometimes called moderate risk mutations, a little bit of a bigger triangle. And then if we have something like BRCA1 or BRCA2, the BRCA genes, that's like a big triangle in the jar. Doesn't mean that person's definitely going to get cancer, but it's going to take fewer of those environmental blue risk factors, marble risk factors, before cancer is going to develop. So here's an example. One of these genes you'll see at the top left is called CDH1. So we see what happens if someone has a mutation in the CDH1 gene. So this is a graph that shows the cancer risk by age 80 for women. The blue represents average risk. The orange represents women who have a mutation in the CDH1 gene. So on the left, we have risk for stomach cancer. In the general population, it's low, around 1% or less. But for individuals with a CDH1 mutation, it's about 39% chance that they would develop stomach cancer by age 80. Similarly, for breast cancer, average risk for women in the US is around 12-13%. For women with a CDH1 mutation, it's over 40%. So a greatly increased risk. Now, these aren't 100%, but they're high enough that we recommend different things in terms of screening and prevention if we know a woman has a CDH1 mutation versus if she doesn't. So this table shows the screening and prevention recommendations from a medical perspective for average risk women and for CDH1 carriers. And I see a glaring typo on my slide here that I will point out. So we typically recommend yearly mammograms for the average risk woman starting at age 40. So that should be a 40. And there isn't necessarily any medical prevention recommendation. There are lots of other lifestyle recommendations that we would recommend for average risks to reduce chance of breast cancer, like physical activity, more plant-based diets, and maintaining good body mass index, avoiding alcohol. But those aren't necessarily medical prevention recommendations. For CDH1 carriers, we start those mammograms not at age 40, but at 30. And we consider actually doing, in addition to the yearly mammograms, breast MRIs. For prevention, we recommend surgical removal of the stomach. There are some screening recommendations for stomach cancer, but really the recommendation is to have the stomach removed before cancer can develop. So pretty significant in knowing if you have a CDH1 mutation versus if you don't. So one way we can find that out is through genetic testing. So how does genetic testing work? Well, we have this DNA, these recipes in every cell of our bodies. We inherited them from mom or dad. They were present in sperm and egg cells. They were present in the very first cell that we were. And so as that cell divided, the recipes got copied with it. So we can get, usually we get a blood sample. We get those white blood cells. You can also do a saliva sample, which frankly is typically mostly the white blood cells anyway. And we send that off to a lab. And what they do is kind of like running a spell checker on your computer, putting the recipe into the computer and saying, do we see any misspellings here or differences in spelling that could change how those recipes work? There are different types of inherited cancer risk testing. One that lots of folks know about is direct-to-consumer testing. So this is testing that is not mediated by a doctor. You don't need a doctor's prescription or an order to have this testing done. You can go into a pharmacy and pick up a kit, or you can go online and order this. And it may look for lots of things. It may tell you information about ancestry, but it may also tell you it's going to let you know about genetic information about health, including cancer. A couple of things to bear in mind about direct-to-consumer testing. And this isn't all direct-to-consumer testing, but this is kind of a general rule of thumb. Usually they focus on low-risk genes. So in that previous graph, these were the ones at the far right, common genetic variants, but low risk. So if you get a mutation in one of these genes, it does not mean remove your stomach. It means higher than average, perhaps, but maybe not anything that would be as consequential. It's a small triangle in the jar. So that's what they focus on. Why? Because they're more common. That's one reason. You have to bear in mind that the genetic testing that happens with these companies does not go through the quality control that you get from a clinical test. So there's variable quality. There have been multiple studies that have shown that when the results of these tests are replicated in clinical labs, we see false positives and false negatives. Companies vary in terms of their privacy policies. So if you're going to have this testing, you'll want to look very carefully at all of that small print that says what's going to happen to your genetic information. Is it going to be released to people without you knowing about it? Who's it going to be released to? What's going to be released? Is anything besides your DNA that's private enough going to be released with it, like your health information? So there's variable privacy that can come with direct-to-consumer testing. And usually they will let you know that the results are for educational or entertainment purposes, i.e. not for making medical management decisions. So if your main reason for doing this testing is because I want to know if I'm at risk for a disease because that's going to inform my medical management, direct-to-consumer testing may not be the best choice. In contrast, there's clinical testing. So this is ordered by a clinician, and we'll talk about who typically might order that here in a little bit. And privacy is protected like other health information. And in fact, it gets some additional protections. So there's a national law called the Genetic Information Non-Discrimination Act that says for most health insurance companies, they can't discriminate based on genetic test result information. Most employers can't discriminate based on that, use that as a reason to not hire you or to fire you or to demote you or that kind of thing. And then otherwise, it's part of your medical record. And just as other medical information is protected in terms of confidentiality, so too is clinically ordered genetic testing. And this is high quality. No test is perfect, but the genetic testing results that we get from clinical laboratories go through rigorous validation and quality control standards, and we consider them to be highly accurate. Typically, clinical tests focus on high-risk genes. sometimes the moderate risk genes as well, but rarely, if ever, the low risk genes, although that's starting to come into play a little bit. The reason for that is because we're looking to do the test to make medical management recommendations. And it's those high risk genes are the ones that change medical management recommendations. So when I say clinicians, what clinicians help with genetic testing? Typically, it's recommended that somebody do the genetic testing or facilitate the genetic testing who's familiar with all of the pros and cons, some of which we've talked about already. So there are genetics professionals whose whole job is to have their mind on this. And so there are physicians who specialize in genetics. Those are medical geneticists. There are genetic counselors who are allied health professionals who also do this. And I've put a website here to the National Society of Genetic Counselors. If you go to that website, www.nsgc.org, there on the homepage is a Find a Genetic Counselor button. So you could click on that to find someone to help you if you feel like genetic testing is something that you might benefit from or want to know more about. But these genetics professionals are certainly not the only ones capable or qualified to facilitate this testing. A lot of oncologists with experience in cancer genetics and genetic testing can do this, or advanced practice nurses or physician assistants who've gotten additional training or certification in genetics. But it's important that you have someone who is familiar with the options. We'll talk about what some of the pros and cons are. So who should consider genetic testing? And in this case, I'm talking about clinical genetic testing, perhaps looking for those high-risk genes. Individuals who have early onset cancer, and that can vary depending on the type of cancer. So there's some childhood leukemias which are typically diagnosed in childhood, and that's not necessarily early onset for that type of cancer. But a breast cancer happening in the 30s, for example, would be considered early onset. So generally for most of the types of cancers we think about, like colon cancer, lung cancer, breast cancer, prostate cancer, under 50 is considered early age. If someone has a rare type of cancer, not always, but often that's a clue that there might be a hereditary cause or a type of cancer we typically see not in, in a different sex. So for example, breast cancer in a man is a little bit more likely to be hereditary than when it occurs in a woman. Family history, of course, that's probably our best vetted public health genetic screening is family history. So knowing family history is really critical. And if you're someone who has had cancer yourself, making sure your relatives know that information is helpful for their health as well. So if someone has 3 or more of a common cancer in their family, like breast cancer, or 2 or more of a less common cancer, then that's a clue to hereditary risk. If somebody develops multiple cancers in the same person, someone having bilateral breast cancers or colon cancer plus an endometrial cancer, 2 different cancers. I'm not talking here about cancer that has spread to different parts of the body. I'm talking about 2 cancers that developed independently. If you notice these things in the family, there's usually a best person to test. And when I say best, I mean most informative. The one who's going to provide the most information for the family is going to be someone who's had one of these characteristics, has had cancer themselves, has had multiple cancers. That's going to be the most informative person to test. Why? Because our genetic testing isn't perfect. And so there are 2 general types of results you can get, right? You can get positive results, meaning they found a mutation. That's shown up here. They look in your jar and they find a clear green triangle. We found the mutation. That explains what's going on. We've got a marker to test other family members for. But there are 2 ways you can get a negative result. A negative result could happen if, in fact, there is no genetic mutation to be found in your jar. That's shown on the bottom left. But on the bottom right, you've got an invisible green triangle. So there is a green triangle in there. There's a mutation, but our test didn't pick it up. And so it's showing as negative. That's not an inaccuracy in the test. The test's only looking for what it knows to look for. but we're still figuring out what genes are associated with different types of cancers and what aren't. So a negative test result is not fully informative unless you've already found that green triangle in the family. So lots of questions people will have about genetic testing, and one important one is how much will it cost? And of course, the answer to any big question like this is it depends. But I will say that I am more optimistic now than I've ever been in my career that finances don't need to be a barrier for genetic testing when it's clinically indicated. So the cost of genetic testing, or whether it will be covered by insurance if you have insurance, depends on whether you'll benefit. And when I say benefit, I mean medically. So are you likely to test positive? And will your results change your medical care? It depends on what laboratory. There's no fixed price for tests in the US. So the same test done at different laboratories can range tenfold in terms of the cost. So it depends on the laboratory. And depends if you have insurance on what specific insurance plan you have. They may have different criteria for whether or not they'll cover a certain test. They may contract with a specific laboratory. So it depends on a lot of factors. And that's an important question. I think a very fair question to ask whoever's ordering the testing for you is how much will this cost? And most of the time, laboratories can give you an estimate. But generally, I would say the price ranges from, this is the out-of-pocket cost if you weren't going through insurance at all. Price ranges from a few $100s to a few $1,000s, again, depending on what laboratory. But in my experience, most people, again, who need the testing pay nothing or less than $100. So it's still, unfortunately, out of the range for too many people, but it's a lot more optimistic. I'm a lot more optimistic now than I was, 10 years ago. So there's some other important questions to ask. Certainly, how much will it cost me is one. But there are other things you'd want to know before having genetic testing. Who has access to my results? Now, a lot of these tests aren't done within the hospital, but they're sent out to private laboratories. So what happens to them then? Now they're bound by the same medical privacy policies because it's a clinical test, but they may be using it de-identified for some type of research. So you might want to ask about that. Who has access to my results and what are they doing with it? What's going to happen with my results once you get them? What will you recommend for me if the results are positive? What if they're negative? What if I decide not to have testing? That should be an option. If I decide not to have testing, what will you recommend I do? What protections do I have against insurance discrimination? I've named some, but that doesn't apply to all people. So it's important to ask those types of questions. Could testing tell me about health risks other than what I already have in my family? So genetic testing, the technology is such that it is not too much harder to test for tens, hundreds of genes than it is to test for one. So a lot of times genetic testing now is done on panels where there can be a whole range of cancer risks or other health risks that are being looked at as part of these panels. So, we can't always predict, what's going to come back, and sometimes we get surprises. So it's important to know, what's the range of things that will be tested for? Am I comfortable with that? And what are the implications, and what happens if I find something that I'm at high risk for that I wasn't expecting at all from my personal or family history? And then perhaps one of the strongest motivations that people have for genetic testing is, what can the results tell me about the health of other family members? But I want to emphasize again that at any level of hereditary risk, there may be something you can do to stay healthy. So this is how resources like the Integrative Health Program here can be useful. So we can keep some of those blue marbles out of the jar. So what we can do to reduce the amount we smoke or to stop smoking altogether, we can reduce the amount of alcohol we drink. If we can reduce body weight if we are overweight, those are some proactive things we can do to keep out of the jar. But there are other things we can do that are more preventive rather than taking away the bad stuff, we can add on some good stuff. And this is like adding on lids to that jar. So we can exercise, we can eat more of a plant-based diet, we can get to maintain a healthy weight. And that's like raising the lid. So even if some of those blue marbles get in, they're less likely to result in cancer. So I hope after this talk, you've been able to say yes to some of these questions. Do you know more about how gene mutations cause cancer? Do you have an idea of the different types of tests for inherited cancer risk? And specifically, I talked about direct-to-consumer testing versus testing through a clinician. Do you have an idea about whether you should consider genetic testing for inherited cancer risk? And do you understand whether you can lower your cancer risk even if you've inherited cancer risk? So thank you for your time, and I would be delighted to answer any questions.
Thank you, Dr. Quillin, for that excellent review. At this point, we don't have any questions from the audience, but some of the things that I wrote down, the data was pretty stark when compared to the deaths from COVID. I know that yesterday we heard we had hit or surpassed the $500,000 mark, and to see the number of deaths from cancer well exceed that, and it's not just a one-time thing. This is something that happens every year. And also to know that a third, now correct me if I'm wrong, but a third of cancer comes from genetic factors. So there's 2/3, as you emphasized, that we really have control over. Anything else you want to know? Two things, if you would comment on that, and also about, second question was knowing the family history is so important. What do you do if you don't know your family history?
Yeah, it's a really good question. So, and it's actually, it's not an unusual reason for someone to be referred to us, is to say, I've been diagnosed with cancer. Maybe it wasn't at a particularly young age, but I don't know my family history. So, our best guess in that case is someone's is at average risk, which means they don't have a strong family history, but we don't really know. And sometimes those people choose to have inherited cancer risk testing, to resolve some of that uncertainty. Usually comes back negative, again, because those high risk genes are rare, but that can give them a little bit more peace of mind in the midst of that uncertainty. The other piece I'll note, and yes, I would say generally for cancer in the population, about a third of it is attributed to inherited genetic factors. Bear in mind that that's including all of those common low risk factors as well. So from a population perspective, it's about a third. But it really varies from individual to individual. And so how much of their jar is filled up to begin with will vary. In the case of limited family structure, or maybe somebody never knew one parent, or someone was adopted and doesn't know their birth family history, that's more of a challenge. But for others who do have that family history perhaps available, the family communication is key to know, what you might be at risk for, and whether or not you might benefit from hereditary cancer testing, how much reassurance you can get from hereditary cancer testing. If someone doesn't know anything about their family history at all, and they have negative hereditary cancer testing, that's probably more reassuring than someone who has a strong family history, say of colon cancer, and their genetic testing is negative. I'm still going to consider that person with that strong family history to be at high risk until I find that green triangle in another family member to say we've got an accurate test for the family or an informative test for the family.
Thank you for that explanation. That makes really good sense. Any final thoughts you'd like to leave us with? And I did have one comment here. I have the BRCA2 gene. Let's see if I can There it is. The BRCA2 gene. When should I begin having my children tested for the gene?
Yeah, it's a really good question, right? Because a lot of times people do this testing for the sakes of their children to find out if their children might be at increased risk, whether or not they need to engage in those preventive behaviors or not. For most of the high-risk genes, and BRCA2 is one of them, we don't see cancer risks increase during childhood. And so that question about, are you going to recommend something different for me, is no, until they get to adulthood. And I don't know how old the questioner's children are. For BRCA2, that's one where we start breast MRI screening at 25. So if a child is a woman and adult, then it makes sense for that person to consider testing. Under 18, professional societies would say they don't recommend it. The two reasons they give for that are, one, it's not clinically indicated at that age. And two, there is this question about, could there be some psychological ramifications, whether that's guilt from parents in passing it on, whether that's treating a child more vulnerably than you would without that information. But I have talked to some families where, they have very mature adolescents. They know the family history, they know the genetic test results, they've talked things through. And in that case, it makes sense. So it really kind of varies family to family. I would recommend having a discussion with, a genetic counselor or a geneticist, so that the whole family can be on the same page in terms of making decisions and how to do that. Now, I will say with BRCA2, sometimes it gets a little bit more complicated. If someone gets a double dose, so they get a BRCA mutation from mom and they get a BRCA2 mutation from dad, that actually leads to a totally different syndrome called Fanconi anemia, which can present in childhood, often does present in childhood. Almost all children will show some signs like immunosuppression or low platelets, anemia, as the name implies. And they have higher risks for things like leukemia and bone marrow failure. Sometimes they'll have some birth differences like absent thumbs and so on. So that's a case actually where it may be appropriate to perhaps test the partner to see if partner's a carrier and there's a chance of that double dose for the child.
And another good argument for having clear communication with your entire team of physicians also. If you do carry that gene and if the child does present with symptoms, making sure that the whole team has all of the information they might need. Thank you for that explanation. So once again, I'll ask, any parting thoughts you'd like to leave us with?
Know your family history if you can. If you've got a health history, pass it along. We sometimes say write it down and pass it on. That's kind of our legacy. A lot of times people feel guilty about letting their relatives know, and I tend to think of it as a gift. This is a gift of information that could help them to live longer, healthier lives. And then the final thing I would say is, genetics is not destiny. That's one bit in our jar, but there's lots we can still control. And so look to those things. And I think it brings us a lot of hope.
Well, Dr. Quillin, thank you for your gift of information today. We
You're
really
welcome.
appreciate your time. Thank you, everyone.